Good afternoon, everyone. My name is Tracy Osborne, and I'm an associate professor in the Department of Management of Complex Systems at the University of California, Merced. And I want to welcome you all to the first panel in a series called Social Justice After COVID-19, Envisioning a More Just and Sustainable World. So this panel is co-organized by Anna Zalek, professor in the Faculty of Environmental Studies at York University, with support from Dali Carmichael, a master's student in the same program. And we're also grateful to the input by Deb Morrison, a research scientist in the College of Education at the University of Washington. As a project of universities in the US and Canada, we want to acknowledge the land and Indigenous peoples of this region as one small act in the ongoing process of working to be in right relationship with the land and people of Turtle Island. So this is the first in a set of panels addressing various themes. While this first one today will focus on public health and inequality, we plan to host others on food, labor, climate change, energy, biodiversity loss, and more, which will bring together practitioners, scholars, and activists who can help us to better understand the current crisis from a social and environmental justice perspective. So today we've asked presenters, all of whom have deep experience and knowledge of the healthcare system, to discuss the impacts of COVID in the communities where they live, work, or conduct research. We've also asked them to address the structural challenges of the healthcare system and the resulting precarity for marginalized communities and for workers such as doctors, nurses, and EMTs on the front lines. And finally, we've asked them to reflect on what COVID now makes possible and what, if any, are the transformative outcomes that might arise from this pandemic. So we're thrilled to have an amazing group of speakers who include Rupa Maria, Associate Professor of Medicine at the University of California, San Francisco, Natalie Mera, Executive Director of the Ontario Health Coalition, Patricia Lopez, Assistant Professor of Geography at Dartmouth, and Abby Neely, also Assistant Professor of Geography at Dartmouth College. Unfortunately, Heather Hastings, health manager with the Sartlip First Nation, and Rithika Goel, physician and public health professional in Toronto, were in the end unable to join our panel as they were tied up with obligations in their health practices as first responders. So before I introduce our first speaker in greater depth, I'd like you to write out any questions that you have in the comment section of Facebook. We'll address some of those questions at the end as time permits. So I'd first like to introduce our first speaker, Dr. Rupa Maria. Rupa is an associate professor of medicine at the University of California, San Francisco, and also faculty director of the Do No Harm Coalition, and a leading figure at the intersection of medicine and social justice. Rupa investigates the health effects of police violence on communities through the Justice Study and is helping to set up the Mini-Waconee Free Community Clinic under Lakota leadership at Standing Rock. She's also the leader of the internationally touring band Rupa and the April Fishes, really amazing band if you get the opportunity to check them out. So I'll now turn the floor over to Rupa. Thanks so much for joining us, Rupa.
Thank you for hosting this. This is great. And I'm glad to be able to be here today. I'm not in the hospital right now, which has been a blessing in the ability to sit back and really examine what's happening, and then also to respond to the crises that are coming in every day from communities, Indigenous communities, Navajo friends who are struggling right now with the infection rates down there, as well as our friends in Lakota territory as they're trying to shore up their response. So I just want to talk a little bit about how COVID is exposing the fracture lines right now in the global systems that have been put in place since the time of colonialism. And what it is showing us is that the suffering of Brown, Black, and Indigenous people is actually built into the structures that have been created through colonization. And that persists today. So that as we're witnessing these increased rates of death in Black and Brown communities, if we're looking at the increased infection rate and spread in Navajo community, this is not by chance, this is by design. And so that the exposure of that design, I think, is really helpful for us right now as thinkers and dreamers of another world, to understand what needs to be create a new world. And so COVID is, I call it the medicine that this virus is bringing us is just this stark exposure. And so we'll talk a little bit about that. So I'm going to do a screen share if that's okay. Yeah, here we go. Can you enable my screen sharing capacity? Somebody, please, if possible. Okay, let's see here. Nope, it's still not done. One more time. Okay. Oh, now I'm a co-host. Now I will screen share. Here we go. Okay, so we are going to talk a little, just for a second, about colonialism and the architectures that were placed. Colonialism, and you can, if you see here, these systems of supremacy and these systems of hierarchies were put in place in order to get the dirty work done of colonization. And these systems have been around for several hundred years. And they have predicated basically who's getting sick and who's suffering the most extreme degree right now. And we see that these systems are recreated actually in every aspect of society, whether we're looking at large at the map of the United States, or you zoom into a different city and look at the breakdown of who's getting sick by zip code, or if you look even in our own healthcare structures. So this is created and recreated throughout our social structures. My interest is in studying the ways in which these supremacies are driving trauma and ultimately driving inflammation. And I find it sadly poetic that COVID is killing us in our lungs through overwhelming inflammation, through really turning up the volume on the cytokine response. And that's when people are often beyond the pale of being able to be saved by what's at our disposal right now. I wanted to bring this up because we're seeing these issues, like I said, throughout every section of our society. This is a map of where I work in San Francisco. So I live in Oakland. I live in East Oakland, and I work at UC San Francisco. And in this map, you see the places that have the most cases of COVID are there on the eastern part of San Francisco. So that region is Hunters Point Bayview region, as well as the Mission District and the Dog Patch. So these are areas that are historically Black and Brown communities. Hunters Point, interestingly, has the sad impact of being a radioactive waste dump, basically, for the Navy. It's a toxic Superfund site that both, the city, the DPA, so many levels have failed the people, the residents of Hunters Point, in creating the obligation of the Navy to clean up the ongoing presence of radioactive material, as well as asbestos and things that are harmful for the lungs. Why I mention this is because we know that zip codes where people have higher exposure to pollutants, that those people's lungs are chronically inflamed. And what we're seeing with COVID is that that those areas where the air pollution is much worse are places where people are having more tragic outcomes. So basically, the setup of inflammation in your lungs from chronic exposure to particulate matter makes it so that once an insult comes, like COVID, it makes it much harder to recover. And this is extremely important because as the planet warms up, the impact of this particulate matter with air pollution is becoming more intense. It already is becoming more intense. And so the need to clean up the air and to shut down those toxic polluting industries that have been designed to be in neighborhoods that are predominantly Black, Brown, and Indigenous, this racism needs to stop. This is one of the main reasons why we are seeing this disproportionate representation throughout our country. Not simply just the lower access to care, so the increased barriers to care of poor Black, Brown, and Indigenous people, but also the environmental and structural racism that relegates them to chronically inflamed lungs. So as I said, that these structural problems are not only present in our communities that we can look at from the macroscopic to the microscopic. The global South will suffer more than the North. The Black and Brown communities will suffer more than the white. But even in the hospitals, what we're seeing is the disregard of labor. And that is a part and parcel of the capitalist project, is the saving of industries while sacrificing the labor force. And what has been shocking to me as a physician has been to watch as doctors and nurses around the world are getting sick and dying. So we have spent trillions of dollars to prop up our economic system in the United States, and we still don't have enough test kits. We still don't have enough gowns or face shields. And this is something that states and required to obtain on their own. There was a New England Journal letter that was just published this last week of a healthcare system CEO saying they had to charter a flight to fly to China to pick up their own because masks and PPE are being seized by FEMA at the ports of entry and then divvied up by the federal government to different corporations to sell, so that states can then have a bidding war against each other to acquire as much PPE as possible. We heard from our partners. We are working with Return to the Heart Foundation, which is a Lakota-led women's foundation, who are working to procure PPE for Indigenous tribes around the country. And they have had their PPE seized as well. So I think that this poses a really interesting moment for us as doctors, nurses, healthcare workers, to understand that the ecology of our health system requires that laborers unite, that our health as physicians is just the same as the health of the janitors, and that the racial and social disparities within our own hospital system are ones that must break down to advance the care of all frontline healthcare workers together in this struggle, so that we do not separate ourselves, but we really dismantle those structures that keep us apart from each other. One other interesting fact I just want to share is this was just recently shared. This is from the California DPH that showed that there were 1,600 positive healthcare workers. What we are being told in the hospitals, that we are being told that a case is not considered hospital acquired unless you're 15 minutes in front of somebody who is a known COVID positive patient. So that means the front desk worker who is exposed to hundreds of people a day got sick, and she was told, and as she is a woman of color, she was told that she wouldn't qualify for workman's comp because it's not a known healthcare exposure. And so what we're seeing is that now thousands of healthcare workers, be they janitors, cafeteria workers, nurses, front desk workers, doctors, we're being told that most of these, when we get sick, we probably just got it out in the community. And what this is doing is it's not classifying COVID as an occupational hazard, which it is, and it's also not allowing our workers to engage workman's comp and get the proper coverage they need for a hazardous workspace. It's as if we were auto mechanics in a place where there were faulty hydraulic lifts and we got crushed. And then we were told that, no, we must have been crushed at home. There's a real known exposure risk of healthcare workers around the world. And right now we're being the way things are happening is very concerning to me about workers' rights. A couple things I just want to share is these graphs to me are interesting and exciting. This one shows the world stocks plummeting, and this is my favorite one, which is the collapse of oil, which is the confluence of many factors. But one of those factors is that people are not driving around as much and people are not flying around as much. And what these two graphs show me is that our collective actions, so our staying in place right now, that people are doing, staying at home, that people are showing a great amount of social solidarity through separation. And that collective action is showing me how strong we are at our capacity to actually tank the entire economy. The economy is actually in our hands, and that the economy is what we drive as the laborers. The hospitals are what we run as the workers. And right now in this pandemic, we're seeing workers being furloughed from hospitals. We're seeing workers having our pay cut. We all get a pay cut right now, but we're seeing industries being saved. And what I would like to just highlight with these graphs is that it really demonstrates the power of workers. And so I would just, I hope that what this can inspire us to see is that we are quite powerful if we can collectively organize ourselves and see and really understand that our withholding of our work, our withholding of our presence can drive huge shifts for the shifts that we need to change the structures that are causing us to be sick. COVID-19 is showing us what the damage of colonialism. And the end game of colonialism is climate collapse. A system cannot survive if that system is based on exploiting and endangering relationships. And so I take this little virus with great humility and as a powerful medicine to wake us up, in not only to what needs to shift, but to our great power collectively to shift it. Thank you so much. I hope I didn't talk too much.
Thank you so much, Rupa. That was fantastic. And thanks for making those linkages between the current vulnerabilities with structural, this kind of broader political, economic, colonialism and supremism, but also linking it to climate change, the energy, the reliance on fossil fuels, but also environmental justice issues. So thanks for really sort of tying together all of those various areas, and we'll definitely come back to that at the end. For those of you who are just joining, please do add your questions or comments in the comment section of Facebook. We'll be happy to address some of those questions at the end. So our next speaker is Natalie Mira. And Natalie has been the executive director of the Ontario Health Coalition for 20 years. She has built the Health Coalition into the largest public interest group on healthcare in the province, representing more than 500,000 Ontarians in its network of more than 400 member organizations and more than 50 local chapters. She is a past board member of the Canadian Health Coalition, where she spearheaded numerous national campaigns to safeguard and improve single-tier public Medicare. Natalie, thanks so much for joining us.
Me. Oops. There, I'm unmuted now, right? Okay, good. Okay. I'm going to switch back and forth from different notes, so I hope that's all right. Looking at the impact, the impact of COVID-19 in our province and also across the country, we can see that there are some common themes that are arising. Themes is not the right word, but where the outbreaks are happening in particular, and the extent to which they're impacting the vulnerable and people are differentially experiencing the outbreaks of COVID-19 depending on racialization, depending on gender, depending on age, depending on ability or disability, and a whole sort of range of social conditions, including poverty. And so echoing a lot of the themes that you brought up, Rupa, about colonialism and about existing inequities and oppression really being brought to light through this pandemic. We are seeing the same thing. We have been working in a few particular areas. We've been tracking the extent of the outbreaks. We're inundated with calls from family members and residents, particularly in long-term care homes, but also patients in hospitals who are being moved out, family members of patients, staff who can't access proper protective equipment or PPE, just across the board, and of course endless media requests for information and more background and so on. I have to say, it's always busy. It's never been like this. It's nonstop. It's overwhelming, and it's heartbreaking. We've taken every day, we're trying to track the outbreaks, particularly in healthcare settings, to see what it's looking like. And what we've found is that there has been exponential spread over we started tracking a month ago, so March 19th, when we found the first outbreaks in long-term care homes. Honestly, they wouldn't have been reported had we not actually started tracking them, knowing that the flu goes through long-term care homes and kills a significant number of people unrecognized every year. And knowing that the homes really have poor infection control and very little way of actually containing something as contagious and as lethal as COVID-19. What we have found is that the outbreaks have grown exponentially. In Ontario alone, there are 283 outbreaks now in healthcare facilities. That's long-term care homes, retirement homes, hospitals, other types of congregate care settings, clinics, and so on. And there are more than almost 4,000 patients and staff that have acquired COVID-19 through an outbreak in a healthcare setting. So the numbers are really enormous. And when you look at them compared to the provincial numbers, you can see that about a third of the total number of people who've been tracked with confirmed cases in Ontario are actually patients or staff in healthcare. And that is not all of them. I mean, those are the ones we've been able to find, but that is not all of them. So our work has been to try and track what's happening in healthcare and respond and advocate for the measures that are needed. They've come very slowly. It's also been to advocate for the uninsured, to try and win access to coverage for the uninsured, at least during the pandemic. I mean, we work on that and support that all of the time, but particularly now. We did, the OHIP for All did win coverage for the uninsured. However, it's not actually happening. And so despite the fact that the Ministry of Health has actually approved it, hospitals are not actually providing care for people, and they're billing them thousands of dollars. We were also trying to support the work, particularly for the homeless, where homeless shelters have continued to have conditions that do not meet the international standards for refugee camps. And yet these conditions continue, and they continue in a pandemic. People do not have even porta potties, nowhere to wash their hands, no bathroom to use that's cleaned. I mean, it really is terrible. And at the same time, as parks are closed and other places are cold, homeless people have nowhere to go. The shelters close in the mornings. They're not open till night. There aren't enough beds. And so very, very vulnerable population. And of course, the spread has started in shelters in a very significant way. So in terms of tracking and advocating around the spread, the exponential spread now in healthcare, in general, in Ontario, and I would say this is true of the other large provinces in Canada, community spread has been relatively well contained. And I don't mean to minimize the experience of anybody who is infected or affected by COVID-19, but definitely in congregate care settings, group homes, places where people with disabilities are supported in group settings to live, retirement homes, long-term care homes, we are seeing an exponential spread of the virus. And the very worst in Ontario, hospitals, long-term care homes, retirement homes, and the congregate care settings, and in addition, the shelters, and now just starting the jails. So there's a theme here, right? What emerges then is that the people who are most at risk, the people who are being most affected by the large outbreaks that are spreading very quickly, are the elderly, they're racialized workers, they are the disabled or persons with disabilities, They are people who are poorer, who are differentially experiencing the outbreaks. How has this happened? Well, in Ontario, like in the rest of the country, we have seen, but actually to a more radical extent than the rest of Canada, we've seen a continued attempt to download and offload patients out of the services that are covered under the Canada Health Act. So if you picture the Canada Health Act as a kind of umbrella that says all medically necessary hospital and physician services will be covered for everybody based on principles of public access and so on. And so if you move those services out of public hospitals into other care settings, they are not covered by the Canada Health Act. And in provinces, they are funded to some extent, but there are user fees in addition, so you have to copay for them. And often, almost always in our province, to a greater extent than other provinces, but certainly across the country, the ownership is also privatized. So it's the privatization of who pays, it's the privatization of the ownership, it's the privatization of the responsibility for care from the public and the nonprofit to the private, to the individual, to the household, often women in the household, to provide unpaid labor, in addition to, for most people from the middle class on down, putting more hours than ever into the workforce in order to stabilize their family incomes. And that has continued over in almost an entire generation, from the 1990s through right through to today. Today, Ontario has the fewest hospital beds left per capita of any province in Canada. And when we plot our province against the entire OECD, where only Turkey and Chile have fewer hospital beds left than Ontario does. And in fact, most of the European countries have double the number of hospital beds. In order to accomplish that, really what they did was they cut the chronic care beds in half. So they cut the care mainly for the elderly, but also for persons with chronic illness or disability and multiple conditions with complex, they call it complex continuing care or chronic care. They cut those beds and just downloaded them or offloaded them into long-term care, residential care facilities, the majority of which, as they built more of them to take the hospital patients, were privatized. Today, the acuity or the complexity and the heaviness of the care needs of the residents in long-term care is extremely high. On the MAPLE scores, that's a score of the care needs of the residents on admission, they are the highest level. By every kind of measure that there is, they are extraordinarily high. Really what they are is chronic care and psychogeriatric care patients now offloaded into long-term care homes where they're funded at a third of the rate of chronic care hospital beds. And then in addition, when they found that long-term care beds were too expensive and that wasn't good enough, they rationed the supply of long-term care beds. There are 36,000 people waiting for long-term care in our province. That number has been over 30,000 for the 20 years that I've been the executive director at the Health Coalition. And so then they offloaded that care to home care. The lion's share of the daily hands-on care done in those settings is by PSWs. There are also RPNs and RNs, but the lion's share of the daily hands-on care is done by PSWs, and they are racialized, they're women, the jobs are precarious. We have did a round last year about, there's a PSW crisis in Ontario, a short staffing crisis, and we did a round of roundtables with them and found that it can take 10 years to get a full-time job, even in the context of critical staffing shortages. The homes do not want to provide full-time jobs with benefits and decent pay. And the long-term care, the for-profit chains, which dominate the industry in Ontario and have moved into the other large provinces as well and increasingly taken over the sector, they own about just over 80% of long-term care in Ontario, have paid huge dividends out to shareholders in the same years, the last 2 years, as the PSW crisis was arising, as they are lobbying incessantly for ever more deregulation and refuse to improve the wages and working conditions. So the idea that you could bring in for-profit providers and regulate them has just not proven true. When we have one regulation like yearly unannounced inspections, they lobby to have it gone. They remove that regulation. We have to push like hell. We have to get massive protests and so on to get it again. And then they deregulate it again and so on. It just is a never-ending struggle. So this pandemic, if it has done anything, it's shed a spotlight on the conditions in long-term care. People are dying in the hundreds, in fact, in the thousands, across the long-term care homes in particular, and retirement homes as well. And the conditions of work are the conditions of care in those facilities. And I think that for the first time, the public and the media from right to left is awake to this in a way that has never happened before. There's a real debate happening across the country for the first time in my 20 years of fighting for this about for-profit ownership of long-term care homes. If we win anything out of this, I think it will be improved care levels and hopefully improved wages and conditions for the workers in long-term care. I think we should also fight for reestablishment of the right to chronic care, slow stream rehab, complex continuing care, convalescent care, all of those things that have been cut from hospitals, where the executives talk about hospitals as only providing acute care, as if, you know, ever in our history, hospitals only provided acute care. They don't care about the elderly, the disabled, people with chronic illnesses who require longer term care in the facilities. And they have taken for years now extraordinary efforts to try and get them out. Under the guise of the pandemic, they've won regulations that have allowed them to move them out wholesale into retirement homes, hotels, long-term care homes, and offload them from hospitals. We're going to have to fight to get them back into public hospitals, and also to reform public hospitals to be much better providers of care for those with chronic care needs. So I'm hoping that across the spectrum, from hospitals to long-term care, unfortunately, home care is really not on the map, although it really is a very, very significant issue as well. But I'm hoping that at least from hospitals across the long-term care, we can push to stop the offloading of patients, to restore and revitalize a vision of chronic care and care for the elderly and people who need long-term care, and also work to push back against the extremely exploitative conditions for the workforce.
Thank you so much, Natalie, for laying out so concretely the vulnerabilities that we're seeing with increased privatization that's happening in Ontario context, and for all of and sharing all of the important work that the Ontario Health Coalition is doing to support poor communities, vulnerable, marginalized communities, and also the tracking, I think is really key. So thanks so much for that.
Thank you.
And now we're going to move on to, well, let me just say also, again, if you're just joining us, please do add questions in the comments and we'll get to those at the end. But now we're going to turn to Tish Lopez, an assistant professor in geography at Dartmouth. Her work centers on the ways that lives are differentially valued and the material impacts of these valuations through the lens of care and care ethics. Much of her work has focused on the politics of international health and development projects in Haiti. So now I'll turn it over to you, Tish. Thanks so much for joining us.
Hey, thank you so much for having me today. I'm really grateful to have been invited into this panel. It's been delightful to hear what everyone has to say. Well, I am a professor at Dartmouth. I'm actually currently on sabbatical this year, and I'm in Seattle, which is the home of a number of my community-based public health research projects, which I actually don't publish on academically because quite often we're doing it under sort of without IRB, which sort of gives it a different tenor to what I'm able to do and sort of talk about. Seattle is not particularly unique in the ways that most cities are. It has a long history of racial disparities in access to housing, wealth, education, and healthcare, among other things. But these are scripted into the landscape into a very north-south divide. And so across the city, although Seattle is often touted as like experiencing great growth and wealth, about 1 in 4 Seattleites actually lives in or near poverty levels. But that poverty is actually heavily concentrated in the South End, which is where predominantly is people of color, and also home to 2 of the most diverse zip codes in the country, just FYI, I always love that. About 50% of African Americans, 48% of Latinxes, and 45% of Native American and Alaska Natives live in poverty in Seattle, compared to about 19% of whites in Seattle. And those numbers are about twice the national average for people of color living in poverty across the country. As many of you know, actually Seattle was home to the first hotspot of COVID-19. Our first case here was January 21st. It was a 30-year-old man who had just arrived back from Wuhan. And at that point, the official numbers coming out of China said that they had killed about 17 people and had only sickened about 400 people. So the coronavirus at that time, when we have this first case, was being described as, quote, not as deadly as SARS or MERS. And so it was raising very little concern among the public health officials here in the region. But that same week is when the CDC started funneling travelers from Wuhan into 5 airports in order to be able to screen them. And that was New York City's Kennedy Airport, San Francisco, Los Angeles, Atlanta, and Chicago's O'Hare Airport. And they also then included Seattle a little bit later. So 2 weeks later, on February 10, we see at Life Care Center in Kirkland, Washington, which is a residential nursing home about 14 miles northeast of Seattle, so getting into a much wider population. Staff started to notice a respiratory outbreak amongst its residents. And they were very slow to respond for a number of reasons. And it wasn't until March 7th, so a full month later, that all the residents had been tested, and then another week before the staff had been tested. And by that time, 2/3 of the residents and 47 of its staff, many of whom work at multiple care centers across the region, had tested positive. And right now, they've been able to trace about 37 COVID-19 related deaths to just that one healthcare center. The governor, Jay Inslee, who keeps showing up occasionally as the snake, FYI, if you watch the press briefings, according to Trump, declared a state of emergency on the 29th of February for all counties across the state. But at that point, they had not actually instituted stay-at-home measures or strong social distancing measures. But it was the following week, March 4th, after Google contractor and a Facebook employee had contracted the disease, that Google, Microsoft, Amazon, and Facebook all recommended that employees start working from home. So we were able to actually institute mitigation efforts very quickly, actually because of a corporate call. About 110,000 people began to work from home in that first week alone. But at this point, bars were open, restaurants, clubs. They were still planning to have Comic-Con, which sees about 90,000 discrete visitors each year, et cetera. And so at that point, the only thing that had been canceled was the Chinese Lunar New Year, which I think is quite telling, given some of the concerns at that point. I think more broadly across the United States, what we're seeing is that millions of people have now lost their incomes. They're losing their health insurance. About 50% of Americans actually receive their health insurance through their employer. We're now seeing millions of children being homeschooled, which is adding to these, extraneous sort of issues around care labor in the home. And highly vulnerable populations who are living in institutions and everything such as sort of long-term care homes, but also prisons and detention centers have been further socially isolated from their loved ones and unable to visit them. But a recent study that actually just came out yesterday has modeled that we're looking at about another 100,000 deaths from coronavirus in prisons and jails in the United States alone. So that's outside of the official modeling numbers, because those institutions often are not actually wrapped into what is considered the population of the United States. If you're at all familiar with how the Census Bureau does all of its counting, right? Like they're actually not considered within a lot of this modeling. So this is really telling us that we're really at a care crisis, and this is where a lot of my interest comes in. So when I'm talking about care, I'm talking about everything from social reproduction, right? Like what it takes to live, eat, feed yourself, but also thinking about it as a societal responsibility. How do we as a society care for each other? How are we being cared for? Both by those who are doing a lot of those social reproductive labors, but also in sort of a broader sort of political sense, right? And I'm going to come back to that in just a little bit. What is very clear is that the biological and social impacts of this disease and this pandemic are being felt very unevenly across Washington and across the United States broadly. We have heard, and we've heard again today, African Americans, Latinx, and Native American populations are contracting and dying from this disease at much, much higher rates than whites are. But unfortunately, the race and ethnicity data right now are very incomplete. So what we're inferring is quite often relying on less than 30%, anywhere from 30 to 70% data completion. And that's only from about 29 states out of 50 plus territories. So just to kind of give you an example of what we're looking at in Louisiana, 70% of the people who have died so far from COVID-19 have been African American, which is more than twice their 32% share of the state's population, as well and well above the 60% of New Orleans, which has been quite hard hit. African Americans in New York comprise about 9% of the state population, but 17% of the deaths. And then if we're thinking more beyond that, though, within the Native American Latinx populations, we're also seeing very disproportionate impacts, but it's very, very geographical, right? So for instance, Navajo Nation right now is now in third place behind New York and New Jersey in terms of infectious rates or infected rates. They had their first case on March 17th. Here in Seattle, Latinxes have been disproportionately impacted, accounting for 17% of cases, even though they represent only 6.6% of the city's population. And that's up from just 10% of the population's infections 2 weeks ago. So we're making a shift out of preponderantly what had been a mostly white disease, mostly elder care homes and elderly people, into the more general population broadly. There are a number of reasons for this, right? I mean, we're quite aware of sort of these disparities, like thinking about the comorbidities that actually exacerbate COVID-19 infections, including diabetes, heart disease. A new study now says obesity, and also chronic lung disease, prompting the Surgeon General, Jerome Adams, if you all have been watching the press briefings, don't know if you have, to make a plea to communities of color to stop drinking, stop smoking, and stop doing drugs. In a way, really highlighting and sort of doing what we see over and over again is sort of pinpoint particular populations for their poor behaviors, despite the fact that we know that whites actually drink, smoke, and do drugs at higher rates than people of color. So people of color are also more likely to be uninsured in this country, are less likely to have sick leave, are less likely to access medical care when they need it. And a recent study has also shown that they're less likely to be given a COVID test despite their need, and so therefore are not able to get the kind of care that they require to be able to combat the disease. I want to be really clear about this, and I think Rupa put this really well earlier, that these aren't just racial data points, right? We're actually talking about the outcomes of structural racism more broadly as they're embedded within sort of the landscape in the United States. For instance, we know for a fact that race is the most significant predictor of a person living near contaminated air, water, or soil. That the people of color constitute 56% of the population living near toxic waste sites, which is double the sort of population of the United States of color. Communities of color are also more likely to be exposed to nitrogen dioxide, air pollutants, and while any air pollutants, will exacerbate and actually make it much more difficult to fight off viral infections, a recent study out of Europe has just pointed out that they believe that nitrogen dioxide pollution specifically may be the most important contributor to fatality cases of COVID-19 virus right now. Then we also have to think about sort of the social impacts more broadly. The ability to work from home is not being evenly experienced. Along ethnic lines, about 30% of whites and 37% of Asians are able to work from home, while only about 20% of African Americans and 17% of Latinxes are able to work from home. Added to this, people of color are also more likely to work in low-wage hourly labor, including many of those jobs which are considered essential labors, meaning that they're less able to enact social distancing guidelines very strictly. Additionally, thinking about other populations who are being disproportionately impacted, I'm very interested in the impacts on women. 2/3 of low-wage workers in the United States are women, and in particular, the majority of people who make up the frontline medical care during the COVID-19 outbreak are women and women of color. So about 91% of nurses are women. 19.2% of registered nurses, 29% of licensed practical nurses, and 59% of home health aides identify as a racial or ethnic minority. And then on top of that, thinking further, foreign-born nurses make up between 15 and 22% of the workforce, depending on the sector in which they're in, even as foreign-born people only make up about 13% of the population in the United States. And so really what I'm trying to sort of highlight here is not only is this disease disproportionately impacting through morbidity and mortality communities of color, but that the care laborers, those who are actually doing the caring for this population, are also disproportionately women and folks of color. On the home front, when we're thinking more, even though a recent survey has said that men now are doing more home care labors than ever before, even just 20 years ago, women actually still in heteronormative households or households do about twice as much home care labor, including childcare and house cleaning, as men do. Added to this, women make up about 80% of the single child households, so therefore taking on a greater proportion of, I think it's about 27% of children live in a single parent household. And then we have about 56 million K through 12 students now being homeschooled in the midst of all of this, 30 million of whom are dependent on low cost or free lunches. And so not only are we facing this massive care labor shortage and sort of concern, but we're also facing greater food insecurity among our poorest and most vulnerable populations. I kind of wanted to end on a positive note. I think I'm so grateful for that question. Like, what are we seeing out of this? I think one of the big things for me is I see glimmers of hope, in the midst of this sort of care crisis. What we're seeing is a broader call to politicize care and care labor, and I'm talking both about unpaid care labor in the home, but also paid care labor out as we're seeing with our daily needs. And activists and theorists have been talking about this for decades, right? Going all the way back. I keep thinking about, Sylvia Federici in the 1970s and the wages for housework, or thinking about Ai-jen Poo and Allison Julian of the National Domestic Workers Alliance, all of which we're really trying to call for not just the politicization, but stronger worker protections, the visibilization of care labor more broadly, forcing it into this public discourse, and pushing for, limiting hours, et cetera. But I also harbor hope on a much larger scale, if I'm being honest. Number one is that in the United States, Congress is able to find $2.2 trillion quite rapidly, right? That they were able to sort of dole out under this crisis as part of the economic crisis. And so I think we as a population have the opportunity now to no longer accept that sort of thing that they say is like, oh, well, where's money going to come from? Well, clearly the money is there. And so I think now that when we're demanding things like universal healthcare coverage, employee-based benefits, such as sick leave, right? Family leave, a living wage, or even proper protective gear, that their excuses can no longer be marshaled in that way, as we also try to sort of close the wealth gap also between folks of color and white people in this country. Number two has been the absolute recognition of the necessity of care labor in our daily lives. Again, both as paid care labor, but also the unpaid care labor. And really one of the things that I've seen happening is that care labor is being heavily de-invisibilized in a really incredible way. So for instance, the first week of homeschooling, Twitter exploded with like, oh my God, these people are saints. How do people do this every day? How do you keep your child like entertained and sort of engaged? We've become more acutely aware of the plight of nurses, nursing homes, right? The kinds of labors. But also the calls for hazard pay for the people who are feeding us, who are delivering our packages, who are, trying to keep our lives moving in the midst of all of this. But more broadly, and which I find particularly, sorry, I'll speed up, exciting, there's a recent Guardian article that identified 100 distinct new methods of direct action that have spanned the physical and virtual world. So we've seen pop-up food banks, vacant home reclamation and occupation, crowdsourced hardship funds, free online medical consultation clinics, mass donations of surgical, materials coming from the private, from private citizens. Youth are starting to mobilize actually more widely and holding weekly rallies and strikes, and the disability rights advocates have been compiling what they're calling a paper digital trail on Google Docs of all the ways that accommodations have been made for non-disabled people during the COVID outbreak as proof that these accommodations can be achieved if there is a will, right? So we're seeing all of this coming together. So in my more optimistic moments, I'm like, revolution, tear it down, build it up, here we go. In some of my less optimistic moments, I'm reminded of the old conservative adage, never let a good crisis go to waste. And I think I want to leave on this note of saying that I think we actually have that responsibility to take that adage back and to actually make use of it. you know, and to start to think and to imagine worlds otherwise. Really, our only limitation, I think, at this point is our own imaginations in the midst of all of this.
Thank you so much, Tish, for laying out. I mean, for that really hopeful, these opportunities that come from the all of the vulnerability of the existing system is now out there for everyone to see. I think folks are now recognizing that there's an opportunity for us to shift in some new directions that would be more supportive of people and the planet, and particularly women and people of color that you've mentioned that are disproportionately affected by this virus. So thanks so much for that. So let's now move to our last speaker, Abby Neely. And Abby is an assistant professor in geography at Dartmouth. She's a political ecologist who studies health, which means she understands health as sitting at the intersection or the interface of biological, political, economic, and cultural processes. Most of her work has been in South Africa, and in addition, these days she's been a first grade teacher and daycare provider. So definitely, the taking on that care responsibility more so now than ever. And I think she'll be speaking to the South African context. So I'll leave it to you, Abby. Thanks so much.
Great. Thank you. And thanks to Tracy and Anna for organizing this. And I just want to say before I start, that comment is a little bit glib. I absolutely appreciate the labor of preschool, daycare, and primary school and beyond that teachers, and I did before, but it was a way for me to highlight the different kinds of labor that we're all being expected to do all the time right now, the sort of collapse, what Tish was just talking about, the collapse of our homework, our home life, our work life, and all of those other things. But I just wanted to be sure that I highlight that I absolutely appreciate teachers. So as Tracy just said, I am a political ecologist. What that means for those who are not geographers is that I understand, and I study health, I understand health is coming at the intersection of ecological and biological processes. And by this, I'm talking about environments in which we live. So these questions around exposure to toxins, for instance, or I'll talk a little bit about living conditions and crowding, as well as the biology in people's bodies, which absolutely varies by their sort of position in the world, their social position in the world. So on the one hand, it's this sort of biological, ecological question. And then I think about political ecology as studying political economy, and that is a hyphenated phrase. And when we academics talk about political economy, we use that phrase to assert that politics and economics can never be divorced. So it's a phrase that's meant to recognize the imbrication of those two. And by that, I mean, not just politics and economics, but other social and cultural forces. So basically, the point here is that I understand health as the interconnections of the biological world and the social world. And that's what being a political ecologist of health is. One more thing I just want to highlight from that is that geographers who are political ecologists are often interested in questions of scale. And when we often think about scale, I'm located in the United States, we think about local, state, national governments, for example. And so what I would say is that as a political ecologist of health, I look at scales that range from the microbe, so here the virus, all the way to the global. So the ways in which global flows of knowledge, supplies, rules, those sorts of things, how these are interacting through bodies, through communities, through nation states, those sorts of questions. I mention that only because the sort of framework I'm using to give my remarks here is a scalar framework, where I'm going to start here for a moment with the microbe. So you all have heard a lot about COVID-19. COVID-19, as you know, is caused by a novel coronavirus. The fact that it's novel is significant here because that means it's new. It means it hasn't entered people's bodies before, which means that we as a population in the globe, not we as the people on this particular conversation, don't have any sort of immune response built up, any sort of immunity to it. It's a virus that works by, quote unquote, people say, hijacking the cells inside of people's bodies, replicating and keeping the immune system at bay. It does this through a protein called an ACE2 that works in the cell membrane that basically stops the immune response. And it does this through cells in your respiratory tract, so your nose, your throat, your lungs, that for the most part, there are absolutely examples of this happening in other parts of the body, but that's for the most part. And that's significant because, so that's the micro, but how does it enter bodies and how does it spread? So it enters your body as you breathe. You all know this now because this is why so many of us wear masks now as we're out and about in the world. So it enters your body as you breathe in infected droplets, or as you touch your face, your mouth, your nose, your eyes, something like that, and it enters your respiratory cells. That's where the virus enters, and it gets into your respiratory tract, and it gets into those cells. Transmission rates, so recent studies we don't really know say that there's an average rate of infection about 5.7 people for any individual sick with the illness. This is data from China, which means a doubling of cases every 6 to 7 days, and that is that's without these social distancing measures that many of us are living under right now. We're also hearing now stories of many asymptomatic cases and folks spreading the disease when they don't even realize they're sick, and also these cases of super spreaders, so people who are spreading more than average. But the average people think right now is about 5.7%. The condition in South Africa right now is it has one of the most in-depth lockdowns in the world. So what I'm going to talk about here are the kinds of questions I have once this lockdown needs to end, because it's not going to be in place forever. So what I thought I'd do is, I've done a lot of work on tuberculosis, and I thought I would use that as a comparison, because tuberculosis is also, for the most part, a respiratory infection. It's an infection in lungs. It's a bacterial infection, which is different from a virus. But I think that there are some points of comparison as we think about it as sort of biological, ecological, and all those. So tuberculosis is significant because right now it's the leading cause of infectious death around the world, and it's most commonly spread with people in close proximity at home. Both this novel coronavirus and tuberculosis are passed through infected droplets as somebody expels them, singing, coughing, sneezing, anything like that, and another person inhales them. This is, of course, more common in tight spaces where people cough a lot. So where I work in rural South Africa is in the mountains. We're coming up on winter. Everybody spends every night sitting together in a very small structure that has no ventilation around an open fire. Anybody who's done this, who's not sick, starts coughing under those circumstances. So you can imagine that this is sort of fertile ground for the spread of a respiratory infection. That's in a rural place. In urban areas in South Africa, urban areas are quite crowded. They have, with lots of people, very population density, they're informal, shared toilets, shared water taps, long lines for food. It's literally impossible for many people in informal settlements or in urban areas in South Africa to socially distance. The other thing to remember is that the spread of these illnesses happens faster the more exposure you have to people who are sick. So tuberculosis, with tuberculosis, South Africa is one of the top 5 tuberculosis countries in the world, which means that sitting around that fire or waiting for that toilet, the chances of you coming into contact with not just one, but multiple people with this respiratory infection is much higher. So the exposure is much higher. From the moment, so that's sort of getting exposed to it. From the moment of contact, from the moment somebody inhales one of these infected droplets, these microbes, the virus enters a different body. And those differences matter. And those differences aren't, of course, people are individuals, but they are, as Rupa was talking about, structured along these sort of questions of hierarchy and supremacy. So in terms of statistics, with tuberculosis, only about 5 to 15% of people who have been exposed to tuberculosis will ever actually end up with full-blown TB. This is different from this novel coronavirus. So we don't really know because of this new information about asymptomatic spreaders, but a very conservative estimate would be that significantly more than 50% of the people coming into contact with this disease are becoming sick. So it's also much higher than tuberculosis. Why are people getting sick in South Africa? South Africa has the largest number of HIV positive people in the world. HIV, as you all probably know, is a disease that literally attacks and undermines the immune system. It attacks particular immune cells, thereby making the person who has HIV immunocompromised and unable to fight off other infections. The point being that other infections prey disproportionately on immunocompromised bodies. So South Africa has the highest levels of HIV in the world at the same time that it has the highest wealth inequality in the world. What that means is that while South Africa has a number of very wealthy people, these are the international travelers who have brought the coronavirus to the country. The vast majority of its population live in dire poverty. And guess what poverty does? It compromises immune systems. Literally, you can see the fingerprints of poverty in the bodies of poor people because of in their immune systems. So here in South Africa, you have this double whammy of a disease that's affected huge percentages of the population with a sort of social condition. And here you see this sort of political economy on the one hand, and the biology that I was talking about a political ecology of health approach. So this has led to South Africa being, as I mentioned, one of the highest burden countries for tuberculosis. In South Africa, tuberculosis is the #1 killer, and it has been for a long time. The number 7 killer in the country is influenza and pneumonia. Number 8 are other viral diseases, and number 10 are chronic lower respiratory diseases. So here, 4 out of the top 10 killers in this country are viruses that are upper respiratory infections. The other viral diseases are not just respiratory infections, but here you have already a country that is facing a lot of death as a result of respiratory infections. So this has the potential to lead to a massive epidemic in South Africa, and one where there's going to be really high levels of death, and one in a place where there's a lot of poverty, immune compromise, and this sort of burden of HIV/AIDS. So as I've said all of that, because we are talking about a little bit of hope, there is one possibility of hope in this underlying health profile, and that has to do with the antiretroviral medications that HIV positive people take in South Africa. So there has been some anecdotal evidence that these kinds of antiretrovirals, in particular, one medication called Truvada, which gay men in New York City have been taking as part of PrEP, it's a prevention medication to prevent the transmission of HIV, has shown in some cases, there has not been yet a systematic study, has shown a lessening of the severity of the disease. And so there is some hope that these antiretroviral medications that so many of the HIV positive people in South Africa are taking might give them some sort of some protection with this illness. Now note that anecdotal evidence is from HIV negative people. So these are diseases for somebody who has HIV positive, but there is still some hope that this might do something. So that's sort of the community and the body spread. So then what's happening on the national scale? So who's getting sick and who's dying? So we have these different kinds of bodies who are affected in different ways. And these different kinds of bodies have to access healthcare. And in South Africa, the matter of accessing healthcare varies very much by race and economics. So in theory, in South Africa, everybody has access to medical care. There are rural communities have mobile clinics. There's brick and mortar clinics. People can get to those relatively quickly with public transportation or walking or things like that. But the healthcare system in South Africa has a doctor to patient ratio of 1 to 1,000. And for uninsured people, the vast majority of the population, it's 32 uninsured people, 32 doctors for 100,000 uninsured people in South Africa. In the United States, for comparison, we have 295 doctors per 100,000 people. In South Africa, there are 18 hospital beds per 10,000 people. In the United States, there's 28 hospital beds per 10,000 people. In the entire country, there are 7,000 critical care beds. In March, only 3,000 of those were open, and this is in both the private and the public sector. That division matters because in South Africa, about 20% of the population has some form of health insurance. Only 20% of the population, about 11% has full health insurance. More importantly, 75% of the white population in South Africa has health insurance versus less than 10% of the Black population in South Africa. So we're seeing a very sort of disproportionate, that a lot of other people are talking about, with a disproportionate leveling of health insurance. And while there is this combination and there have been discussions between private and public sector facilities, it's not clear what's going to happen if there's overflow. The South African healthcare system, to one of Tish's points, is a largely nurse-driven system, which means it's largely female. And it's also a system that is supported throughout the country with community health workers who are people who have very minimal training, work in communities, and they are, for the most part, female as well. So how do you access healthcare? These are other questions. How do you get to the hospital? So there is a healthcare system, but a lot of people have trouble accessing it, particularly now, given that lockdown has made it so it's hard, there's no public transportation. So if people are really sick, they can wait for transportation. They can hire they can pay somebody to drive them, which is expensive, or they can call an ambulance. We did a study in rural South Africa that found about half the time ambulances don't come when you call them, and the average time for an ambulance to come is 7 hours. So you can imagine the stories you're hearing from other places, what kind of impact that will have on ability of somebody to live. So, and if what we're seeing in the United States is any indication, once South Africa opens back up, Tish has talked about a lot of these stats, the cost to people will be huge, all brought from this international travel. So in the United States, the latest statistics show that mortality among Black Americans is 23.1% compared to 8.6% amongst white Americans. These are national statistics. There's 23 deaths per 100,000 African Americans. In New York City, that's 88 deaths. In Michigan, it's 72. African Americans make up 11% of the population, but 28% of COVID-related deaths. I believe Tish gave us that statistic directly. The same is going to be true in South Africa, but in South Africa, the population is 76.4% African, which means that the burdens on the healthcare system are going to be just extreme. So what's the South African response been? As I mentioned, there's been a total lockdown. And this lockdown looks different than it does in the United States. There's army in the streets. They're checking people's papers if they're trying to move anywhere in the country. This is working effectively to flatten a curve, to reduce transmission, to do all that. But it's also reminding many people who live in South Africa of apartheid, of the system of minority rule that ended 26 years ago. And the other thing that people are talking about are the ways in which not everybody can do this. Shared toilets, these other sorts of questions mean that people are still coming into contact. People are also noticing the ways in which this is criminalizing the everyday acts of survival that people need to do. So if you're being stopped by the police, if you're being sent home, you can't go get water, you can't go get food, and you can't do the other things that you're doing to sort of live your life. So that's sort of one of the downsides. A couple of positives that have come out of South Africa that people are thinking about. One goes back to that question of community health workers. So there's a network of community health workers who are actually very well-trained disease tracers, in particular for tuberculosis, to go back to that. So South Africa is employing an army of contact tracers already in a way that many countries don't have the infrastructure to do that. And so that's one interesting thing as a public health response that's sort of already in place, and an interesting upside to a downside of a healthcare system that doesn't have enough professionals, but has this sort of larger infrastructure. The other thing is that on Tuesday, the president of South Africa, Cyril Ramaphosa, put forth a huge stimulus bill that many people who are often critical of the South African government are looking at as offering new kinds of possibilities to reduce inequality in a way that they haven't seen before, which is an interesting thing. And I just want to say one last very quick thing, which is this question of the global scale. So once South Africa opens back up, the question is, South Africa is the most industrialized country in Africa. It is a middle income country. It's not a low income country. At present, about 20% of the national budget for healthcare related to infectious disease comes from international donors, but there is no capacity in its healthcare system. So the question for a country like South Africa, and even more for a country like Malawi or a country like Venezuela, is where are they going to get the PPE they need? Where are they going to get the money to fight the disease? Once the vaccine comes on land, where are they going to get the vaccines? And so I think we're going to face a lot of really stark questions about solidarities in this age in which nationalism is coming to the fore in a way we haven't seen in a long time. So that's my sort of worry to end it. So thanks.
Thank you so much, Abby, for kind of reminding us of the power of a political ecology approach that allows us to draw some of those connections between, from the virus to how that impacts the body, to some of these sort of national, sort of care, actual, care in hospitals, who has access, who doesn't have access, who's disproportionately affected, and kind of link that out to policies and sort of the global context. I think that was really powerful. So unfortunately, Rupa had to leave the call. So we currently have Tish, Abby, and Natalie's it's still on, but we'll jump back on in a minute. But I wanted to maybe ask a couple of questions, and then also give an opportunity for you all to ask each other questions to see if there's if there's some sort of response or some questions that you had from the other presenters. But maybe I'll actually start. There's a question here from the comments section for you, Abby. So you mentioned these antiviral medications in South Africa, and given what you've just told us, what are the potential of these meds to actually lessen the effects of COVID? And also, is there any worry about these meds being suddenly inexpensive or unobtainable for the existing populations that depend on them?
Great, thanks for that question. I just want to start and say that I am not a medical researcher, so all I know is this anecdotal evidence that's coming out about Truvada and as PrEP, and so I think that there is potential. The other thing I'll just want to explain is the difference between the coronavirus, which is a virus, and HIV, which is a retrovirus, which means that the medications may very well be different. I'm not exactly sure whether retroviral medication, although I think there is some thought will work with the coronavirus. I think what we've seen with chloroquine, which was the hydrochloroquine, which was the medication that there were some very, very early, very small studies in France that showed some success with, and then that was taken up by the United States president, and therefore went into short supply. I think we absolutely need to be worried about that as a possibility. I think so I think that's a really good question and something we should be worried about. And we should especially be worried about it in a place like South Africa, perhaps more in places further to the north in Africa where governments have less money, because the places where these medications are going to be harder to get if there becomes a global run on them are the places that are the poorest places in the world. So it is a great question. I don't know exactly. I think that there is some thought of starting to give Truvada at least to healthcare workers in the United States, but I don't know if that's going anywhere or if it's not.
Mm-hmm. Yeah, thanks for that. So there's another question that speaks to, let me see. So there's another question that's trying to understand how these disparities of marginalized populations, how those differ between kind of a U.S. highly privatized system and a kind of more socialized system that we find in Canada. Anna, you're also on the call. I don't know if maybe you can also, since Natalie has stepped off, but if either of you have a sense of kind of how these disparities change based on the level of privatization, even sort of broadly, if you can kind of comment on that.
I can comment a little bit on the insurance aspect. I had actually a much longer talk prepared and was hoping to talk about insurance. I think through privatization, I mean, one of the things that happened with the ACA that was enacted in 2010 is we saw a steady decline in the uninsured. But since 2017, we've actually seen an increase in uninsured for a number of reasons, having to do with attempts to gut it, state by state Medicaid and Medicare expansion denials, new programs being put in place for like you have to work now in some states to be able to even access Medicaid, Medicare, never mind that many people who need Medicaid or Medicare can't actually work. So we've seen a really deep unevenness, and what you'll actually find is it's following along the kinds of lines you expect. Predominantly Republican voting states are the ones who are seeing bigger restrictions on who can access, and also the kinds of services that they can receive through that. The variability state by state is quite wide. Whereas what we're seeing in more Democrat states, not so much. I think one of the other issues that I think we're not going to be able to really understand until much later is that when Trump had started to insist that people who were either hoping to apply for or were in the midst of applying for a green card should not access any social services, he was hinting at that from the very beginning, and it didn't actually get enacted until, I think, 2018. Under the public charge rule, you saw a massive pulling back of immigrants trying to access some of those health services. And then we've also seen a massive drop off, at least here in Seattle, from what I understand, in undocumented migrants. So Washington State has been very generous and actually funds. They have a separate Medicaid, Medicare expansion that is not federally recognized. And in fact, they got sued about 10 years ago for using federal funds to insure undocumented migrants as well. I don't think we're able to really pinpoint that right now, but I think we are going to start seeing, I think retrospectively, we're going to be able to sort of calculate those adjustments. When this pandemic started, we had about I actually have the numbers, I'm not going to guess, almost 28 million were uninsured in the United States, and another 29 million were underinsured, which means people are not going to want to access healthcare if they're going to have to pay for it. And I think I mentioned earlier about 50% of Americans have employer-based health insurance. And so far, 26 million people have applied for unemployment, right? And so we're looking, the numbers are going to be staggering. During the 2007-2009 recession, 9.3 million people lost their health insurance through their employer-based. I think that's where we're going to start to see the real difference. We already have a lot of hesitancy accessing for in communities of color for obvious reasons, massive health disparities in terms of access to pain medication, having their concerns taken seriously, et cetera, but also just the higher likelihood that they actually won't have insurance as compared to the rest of the population. So yeah, I think it's a little early to say exactly how, but I think there are going to be a lot of studies at the sort of tail end of this as we move forward.
So you also talked a lot about these comorbidities. And do you have a sense of how care and treatment, like who has access to care and treatment given this sort of prior history of health conditions? Is that having an impact given the sort of the limits on the amount of ventilators and other equipment? Do you have a sense of who has sort of the question of access in the context of these comorbidities?
I think what we've seen in previous studies is, well, number one, that people of color tend to be made sort of given the personal responsibility lecture, right? You need to lose weight. You need to improve your health, and then the Surgeon General helps reiterate this sort of on a broader stage. That has actually led to a growing reluctance to access healthcare in the U.S. But I think we also have to think about these longer histories of racialized medicine more broadly. African Americans in particular have borne the brunt of a number of eugenicist, experimental, nefarious health interventions, right? And it's everything from the more obvious things like Tuskegee to some of the experiments that were being conducted in the 1990s on young African-American men, that were supposedly supposed to help with particular things. Anthony Hatch actually has a really great book. I love to plug him and I think also Dorothy Roberts does a beautiful job on this with Fatal Invention, and we're also trying to see a real conversation about sort of the targeted interventions that are supposedly sort of these genetic interventions that are really reifying notions of racial science, like it's sort of a new racial science at the genetic level that is sort of about managing sort of individualized responsible behaviors. That then I think is what has led to a lower rate of testing for African Americans and Latinx populations when they do show up with the symptoms. Even, it's like, well, you probably have something related to sort of your poor personal health habits.
And I think, since you and I have talked about this, there's also this question of crisis standards of care that are starting to come. So in moments when there is a shortage of beds, how do you decide who gets those beds? And those can be about expectations of who is going to survive this. And those expectations they are meant to not be biased, but in not being biased, they focus on things like pre-existing conditions. And we know that pre-existing conditions, as Rupa said, the sort of structures of what I would have called settler colonialism, but colonialism and racial discrimination and racism and racial capitalism are baked into the bodies of different individuals. And so the ways in which those crisis standards of care will then choose white life over the life of people of color simply based on a standard that looks like it's objective because it's about who might survive and who might not. But the pre-existing conditions we know that make somebody more susceptible to a more severe case of this are racialized, absolutely. So
And these are also, these vary state by state. So the new crisis standards of care were just released for COVID-19 about 2 weeks ago. You know, and they reiterate certain things, but some of the old crisis standards of care sort of guidelines are actually no longer attainable. So it used to be that your very first structure was to look at organ failure, right? So it's sort of this process of assumptions about organ failure actually have little correlation within the COVID-19 sort of disease picture, if you will. But if you also look state by state, pre-existing conditions can be as varied as mental disability. In Alabama, they actually have it built in there that mental disability is a pre-existing condition that can drop you off the list for whether or not you have access to life-saving therapeutics. In other states, it can be these kinds of comorbidities that are chronic conditions that many people live with. Most states go on an age basis. So the idea is not the elderly will be the first to sort of get dropped off. And then you have places like Oregon that actually have the option to do what's called a raffle system. So basically, it's not even first come, first serve, but it's just whoever's name gets pulled out of the hat. And I think this actually speaks to a bigger problem with our public health structure broadly, right? Constitutionally, pandemic preparedness is, managed at the federal level, but the actual public health day-to-day is handled state by state. It's protected under, believe it or not, was protected under Commerce Clause, interestingly enough. Long history there. And that's been part of the battle of getting some kind of chain of command that can allow for instance, a national set of crisis response, right? Or ensuring that we're getting PPEs and masks and ventilators distributed evenly and where they're needed, as opposed to in this haphazard sort of economized way or marketized way, as we've been seeing over the last 4 months or 3 months, I guess.
Thanks so much. Okay, I think we've got a question here for, well, actually, we're kind of like getting close to the end. I wanted to kind of bring it back to more of a broader kind of political economic. If we look at the healthcare more systemically and not this disease, not just as a series of symptoms, but thinking about sort of the underlying causes. We've mentioned the environmental injustice issues, but also if any of you could sort of speak to the issue of food, which is so fundamental in health. And maybe if you could talk a little bit about how you might be seeing that either in Ontario, if access to food has been an issue, Natalie, or in the Seattle case. Oh, Natalie, you're on mute.
I'm going to let you go first because I'm just sort of thinking about, I'm thinking about how to answer that. How about Seattle first?
I think Seattle is a pretty typical city in the sense that in low-income communities and communities of color, there's a pretty severe poverty tax. I believe it's around 6% in this city. There are also food deserts, right? So once you move into certain areas, you've got an issue around access to fresh fruits and vegetables. And then on the other side of this, and I think this has been particularly pernicious here in Seattle, we have this issue of gentrification. So that has been very rapid over the past 10 years in terms of pushing out families that have been multi-generationally in particular neighborhoods. And so those that are staying are now finding themselves stuck with Whole Foods, for instance, right? Not exactly affordable to most people to begin with, and maybe not even offering the kinds of foods that are part of their diet, right? So, for instance, Red Apple has been pushed out, and it's a small, locally family-owned chain in the Seattle region that actually had been all along sort of in Seattle for a long time, particularly the African-American community was in a corridor of about 9 to 12 census tracts. Like that's how very compact it was. And so Red Apple had actually positioned themselves there, and then the Latinx community and the Filipino community then is sort of in this mid-range area, and then you hit southern or south King County region. You know, you could find things like the foods you wanted. You know, I could find my cactus. I could find, you know, I could find certain kinds of, they're gone. They're getting wiped out. They're getting closed. The one in, for instance, Beacon Hill, which used to be one of the most diverse zip codes in the United States. In fact, was the #1 most diverse zip code and is now number 15. Due largely to gentrification, is now a wall of kombucha, right? Like, I can no longer get my cactus. Like, I can get, you know, 50 different kinds of kombucha, which has also been found to be, what's the word I'm looking for? Like, less inviting. I'm not sure how better to put that, but it becomes those places that we're familiar actually become closed off to you. When they're not actually providing what you would want, even when you do have access to available vegetables and certain kinds of, you know, a broader range of food. And that's been a big issue. I think in Seattle, food has been a major issue as gentrification unfolds here.
So Natalie, I don't know if you have comments there, but I'd also be interested if you could speak to, there was a question about sort of the increased privatization of healthcare in Ontario. And if you could speak to what are some of the changes that might improve care and services, particularly to people of color communities, low-income communities. How might sort of a more socialized medicine in Canada be improved to be able to better meet the needs of some of the communities that you serve?
Mm-hmm. Okay, so on the food question, I think really what I've seen, I don't have any numbers, I just have sort of observations during the pandemic. And what I've seen is when I go into downtown Toronto, so the city center, the truth is that housing is so expensive in the city center now that even rent is beyond most people's reach, many people's reach, and people have had to move out and further out and further out. When you're in the suburbs, that's where I live, in a kind of poor area of a suburb, it's extremely busy. It's like nothing is happening. You know, there are a lot of stores closed, but the grocery stores are open and life sort of goes on as normal. All of the things that Patricia was describing around food deserts and all that all exists at, you know, all the time. But in terms of what has changed, I think the situation is extreme for people who are homeless or underhoused. I think the situation in terms of access to food, access to services, so many things are closed that access is a real problem. On the other end, in terms of food production, our farming here relies enormously on migrant workers. It's extremely unjust. It's extremely exploitative, oppressive situation to begin with. Now, in order to allow the farms to start work, they are bringing in migrant workers, but they have to self-isolate for 14 days. There are all kinds of questions. There are always questions around their access to healthcare. They do have access to healthcare after a period of time and so on, but all of that, of course, is cast, you know, all of the pitfalls, all of the lack of supports and services are cast in a much sharper light now with a pandemic and people, you know, really traveling from Mexico often or the Caribbean into Canada to pick vegetables and pick fruit and plant and so on in conditions that were always unfair and terrible, now having to self-isolate, now without the healthcare support and so on that they need. Those are my thoughts, just initial thoughts about food. On how can healthcare be improved coming out of the pandemic to better serve racialized people and marginalized communities. I really think that the fact is that it's both the workforce that is racialized, serving communities who are racialized often, and serving in the less funded, the less supported parts of healthcare. I think that the congregate care settings will see change. What that looks like, who wins the change, I think is really a toss-up. We could face a period of very severe austerity after this. Governments have spent a lot of money, frankly. The federal government in Canada has spent a lot of money. Our provincial government has really tried to run its way through the pandemic and say all the right things, but really keep they're extremely right wing, keep to a kind of program of their framework of fiscal restraint, as they would call it, or austerity. Still, at the end of this, there will be a battle between those who want austerity in order to pay for it and those who want to see something better and more socially just emerge from that. I don't know which it's going to be, but I'll tell you, we're going to fight like hell to ensure that actually these structures that were never perfect in the first place, particularly public hospitals not being very responsive to their communities, not being as democratic as they ought to be, not having governance that reflects the actual demographics of the populations that they serve, not in class, not in terms of race, not in terms of ability or ableism, all of those things. The ageism of the healthcare system, I think, has been laid bare. People are not even being given access to treatment. The elderly are not even being taken to hospital. In many cases, they're being left in place with support, even without really giving people informed consent, which is cornerstone to our healthcare system. Those things are getting more and more exposed. Can we win the peace at the end of this? Can we win a situation in which we reform these institutions and these structures? I think it relies on us to actually set out the vision of what that might look like. It means democratic governance. It means that governance has to reflect our actual communities in real ways. It means there have to be democratic processes, a feedback loop. Public health care is only public if people who provide care, people who receive care, all work together to make that care reflect their needs. There shouldn't be a tyranny of patients over staff, nor of staff over patients, and certainly not of bureaucrats and a kind of technocratic class over everyone in the system. So I'm hoping if we can build consensus around models of care that address the shortfalls that we've seen, if we can win public support to those things, we can win. But we have to know that the private sector is always jumping in with models and ideas, and always where there's public policy failures, they're right there with some way to expand their market and increase their profits. And we're going to have to overcome that. I think there's going to be a gargantuan tussle at the end of this. And I don't know, but whenever we fight, we win. I think we have more deeper support for public health care than ever, and it was always very deep, than ever now. I think we can move people. We have to find the tools that people can use to make visible their opposition to privatization, to make visible their support for new models of care that better serve people. Sorry if I went on too long.
No, thanks so much, Natalie. And I think these types of spaces are ideal for sharing what are some of the concerns of existing, healthcare systems, and also allow us to imagine and envision something new. So thank you so much, all of you, for your time. This has been really a fantastic. I think we've gotten so much out of this conversation. So really appreciate all of you taking your time. And I think we're gonna close now. So thanks again.
Thank you for having us. And it was so nice to meet everybody.
Very nice to meet you all. It's been an honor. Thanks.
Yeah, really wonderful to meet you all too.